we'll just get started in a few minutes, trying to get a mass of people joining. I think I might have been muted before, like I've never been on Zoom before, but if you didn't hear me, you can put your name, pronouns, and role in the chat. Okay, I think we can get started.
Okay. Hi, everyone. My name is Stacy Sandy. I am the data analyst for CCQC. Today, Amber will be presenting on the most recent collection we had. Amber is the new QI, if y'all are not aware of it. She presented last month. And then we also would like to thank Harley Swenson, our intern, who helped put this presentation together for us. Just so you all know, last year we started this collaborative with 11 participants, and this year we have 20 participants in the 2022 SUD collaborative. So you all are aware of the data collection we are presenting today. We have 18 hospitals that presented hospital level data, while 12 hospitals presented patient level data, with a total of 96 patient level submissions. Just to give you guys an update, we want to thank everyone for submitting the data submissions. We have these hospitals to thank for their hospital level data, as well as their patient level data. If you notice that your hospital is not up here, this is data collection as of July 30th, so you may have submitted something after that, or if there are any data quality checks that we can do to ensure that we did receive your data, please reach out to us. You can certainly connect with us and make sure that we have your data collection. That was due on July 15th. And just as we practice what we have been encouraging y'all, the format of this presentation will be in the PDSA cycle of a Plan, Do, Study, Act. We hope to present what we planned to do back in January and what we did do in the past following few months, and what we plan to study upon the data that we have received and what we act upon those. Just as a reminder to y'all, we had initially began collecting data on a monthly basis for qualitative data, and then we plan to collect quantitative data quarterly. These are methods that we had planned to do, and I will go in more detail next as to what we meant by quantitative and qualitative data. And Amber?
This slide outlines the project goals that were originally set by CPCQC in 2021. We wanted to highlight specifically in the purple here that sustainability means consistently screening at or above 90% for 3 consecutive data collection cycles. And currently, none of our participating hospitals meet this goal for sustainability, which is a reasonable place to be at this point. But we wanted to let you know that in 2023, as our cohort grows and evolves, we're going to be revising these goals to focus on clinical care for positive screens. So not just screening, but what are we doing to act upon positive screens? And then we're also going to be focusing on this type of sustainability planning for the hospital sites that are achieving the 90% screening goals.
So again, as I mentioned previously, we wanted to talk about the different ways that we planned on collecting data. More specifically, our monthly qualitative data, what we have been collecting and why we collect this information is more of, we're utilizing this as a status report or as a check-in from y'all. So when you submit your monthly qualitative data via SurveyMonkey, you're giving us information to let us know how we can support you, what's going on with you, if you have any tests of change that you've adopted, or if you are also running any PDSA cycles, or maybe perhaps you're running into challenges, or you need some support and some struggles, and you would like to reach out to us, who we can reconnect you with. So we want to hear that through your qualitative surveys, and continue to let us know if you have experienced some wins as well. We want to celebrate that with you. So we don't expect you all to be QI experts experts, but please do give us your qualitative feedback that we know where we can introduce you to new QI. Actually have Amber connect with you in those QI plans. Now, just as a reminder, our quarterly quantitative data, yes, we just collected our quantitative data that was due on July 15th. Again, we're going over that today. Our quantitative data consists of different pieces. There's the hospital level data and then the patient level data. This is all collected by a red cap, so I'm sure you all are aware of this, but just as a reminder, we collect hospital level data so that we can collect all data related to which protocols or screening tools have you implemented, the number of patients that you admitted for birth, and the number of patients that are race and ethnicity, aggregated, and then insurance type for those that are admitted as well. We also want to know how many patients were screened for substance use disorder, anxiety, depression, ACEs, and social determinants of health. And then from there, we go on and actually collect data that are patient level data that are specific to those patients that are identified as using substances during pregnancy. We break that down with race and ethnicity of those patients, newborn information, substances used by those patients, as well as clinical care procedures, whether they are receiving consultation from social workers, counseling on, and also receiving any kind of treatment, and then in referrals. We also collect information on naloxone practices as well. Now, this is our, what we've been doing is collecting our data collection timeline based on these monthly and quarterly kind of data deadlines. So we hope to continue this kind of data cadence, and we encourage y'all to continue with your data collection methods. Please do reach out to us if you have any concerns in reaching these deadlines that we have here.
So as a team here, we're moving into our study phase of our PDSA cycle, and we wanted to start with visual before we jump into specific data that we covered today. I think that this visual helps understand the levels of data that we're collecting, all the way from the top of hospital level that shows us the number of patients admitted, to the number of screenings that were completed, and all the way to the patient level data that's just the clinical management for screens. All of this is under the umbrella of knowing the payer and the race and ethnicity data in order to identify healthcare disparities. I think the funnel can help you visualize how we're implementing and identifying this data. Of course, the data that we're going to cover today becomes even more granular than what we've listed here. We're going to talk about specific substances that were identified by our patient level data submissions, and then really specific clinical management that's specific to opioid use disorder. But again, I think this gives you a good big picture to sort of understand how we're going to present the data for you today, top to bottom. In our PDSA cycle, of course, this is our study phase. We're looking at our data and we're sort of analyzing it and deciding what went well and maybe where we could improve. But keep in mind that the data that we received is relatively limited. Less than half of the cohort submitted data for most of these measures. So although the data is limited, I think there's some valuable points that we can take away from it. And we want to highlight those points today and learn what we can from what we have.
That's a very good point, Amber. I kind of skimmed over that, but of all the hospitals, as I mentioned before, of the 20 hospitals, we did only get 12 of those hospital submissions. And I kind of mentioned that in our patient level data, we did get 96 submissions, but of those hospitals that submitted is also very small compared to our overall 20 cohorts. So here we're going to move on to the actual data collection findings and look at our quantitative data that we have been collecting for the first time this year in 2022. This is the hospital level data. And as we look at this, bear in mind, we are again looking at the small number of submissions that we received so far. We do want to appeal for those that have entered a protocol or screening tool for social determinants of health. Almost 40% of our hospitals have implemented some kind of screening protocol. And that's here. So we want to hear from y'all and what y'all are doing. In relation to our screening rates, this is based again on the number of submissions that we've received. And of those submissions, this is on the patient admitted for birth, we have 66% are being screened for SUD, while 91% are screened for depression and anxiety, and 75% are being screened for social determinants of health. So far it's looking very good. If we compare this to last year on this slide, from 2021 to 2022, the screening rates are going up and have improved for PMADs, which is anxiety and depression, as well as, if you look, we're still in the 90%. But if we look at SOUDs, the screening rates have declined. Keep in mind the overall number of patients admitted to the number of patients screened is a contributing factor to these overall percentages. So as we screen more, hopefully we can stay at our goal of 100%.
As part of our study phase, we're also analyzing the data, and today we're going to share some of our insights that our team came up with. But I want to be clear that the wins that we're celebrating today belong to all of you who are implementing these practices. The wins are your own, and they aren't simply data points. They represent actual patients that are impacted by the care that you're giving. And for the challenges that we're going to bring up, we see these as an opportunity for improvement, and we're here to partner with you to address those challenges. So first of all, PMAD screenings above 90%. This is a win. We want to encourage the hospital sites that are meeting this criteria, celebrate what you're doing. And I would recommend that you learn from the workflows that you've developed around depression and anxiety screens, and see if those same workflows would help you increase substance use disorder screening. We need to see some improvement. The level of substance use disorder screenings that we're doing, we're at 6%. We'd like to see that at 90% or above. And so whatever workflows are working for the screenings that you're doing routinely, see if you can mirror that. And because 4 Minutes of Health and ACEs screenings are relatively new to this cohort, if your hospital hasn't already chosen a screening tool to use for those, now's a great time to do that. Decide as a team which screening tool you want to do. We're asking teams to tell us which tools that they're using so that we can share that widely. If you need an idea for evaluating those measures, and go ahead and start to do workflows around that. Based on the hospital level data, we would suggest that you develop some specific aims for your site. Of course, CPCQC developed 90% as a goal for our screening rates, but that might look different for what's realistic for your hospital site, especially if you're coming from a really low screening rate. So I've given some examples here on this slide of some specific aims that you could set. An example would be by December of this year, 80% of all patients would be screened for substance use disorder using a validated tool. I think that this sometimes feels like a formality, setting an aim like this, but it can be a really valuable tool to motivate your team. If they have specific numeric goals that they're aiming for, not only can you share with them what your current screening rate is, but what we're aiming for so that they know where we're headed and where we want to be.
Thank you, Amber. And now, again, we are still in the study phase, and we get more into looking at our data that we have received so far. This is specific to the patient level data. Again, we had 96 submissions of those. And as noted, we are identifying those patients that have identified themselves as using substances during pregnancy. Some of the notable findings we have here in specific to the range of gestational age of our patients from 13 weeks, 7 days to 41 weeks, 5 days, and the birth parent's maternal age from 19 to 43. As we can see from these diverse ranges of ages, we're indicating it's hard to kind of decipher who is a patient that may be substance use. So keep that in mind. We are happy that you're collecting all this information that we can't compare and identify disparities in health without this information. So we do look at also the payer information or insurance type of those patients being reported. It looks like a large majority at this moment are reported with Medicaid and Medicaid plan, while private insurance follows next, and uninsured is reported as 1%. We want to highlight how important it is to have these teams submit hospital level data in order for us to make comparisons on the patients that were identified as using substances and the insurance types that they have, to the overall whole submission of hospital level. Moving forward, we also have Amber, who touches more on the QI perspective of this.
Yeah, so as Stacey said, we only have 11 hospitals that are included in the previous slide that identified maternal age, gestational age, and payer data. So we're really curious to know, what is your workflow for collecting payer information, both on a hospital level and at a patient level? We've heard some hospital sites are having trouble getting this data and or have some concerns about submitting this data to us. The goal of using payer information is to identify to identify disparities in healthcare delivery. We want to make sure that all patients are being offered screening, and that doesn't depend upon what insurance or how they're paying for their care. So if you guys can give us feedback, you can do it now in the chat. We're moderating the chat. If you want to send us an email, we'd love to know, how are you collecting payer information? How is it reported by your EMR? Who is collecting it? And what struggles you have in submitting that information to us?
And in line with that data collection on insurance type or payer information, we look at the level data in regards to race and ethnicity. Now, again, this is a small portion of the race and ethnicity we received from patients that admitted for birth that have been identified using substances. So as a whole, we appreciate y'all to continue thoroughly submit your data for hospital level data and patient level data, so we can compare the patients that were admitted for birth, what were their race and ethnicity, and then again, of those screened, what were their race and ethnicity, and then of those that screened positive, what are those race and ethnicity patients. So that way we can see how it all drills into one another. Just looking at this, we have the majority coming in. I won't read it for you, but you can see how the race and ethnicity disparities have gone from white, Hispanic, Native American, and Alaska Native to African American, multi-race, race, and other race. We know that there are challenges with this, so I will move on to the next slide and allow Anna to touch on that.
So we've got here on this slide, we realize as a team at CPCQC that there are challenges with the way that our collecting race and ethnicity data. The current data collection protocol, as most of you know, is currently asking for only one option for race and ethnicity. And this more than likely differs from the way that your EMR is collecting it, where they most likely separate by race with 5 or more categories, and then ethnicity for Hispanic and non-Hispanic. So we are currently looking into this issue. We plan to get feedback from you all on how you're collecting race and ethnicity data currently with your EMR, because we'd like to more closely mirror what you're already collecting. We're also partnering with CDPHE and asking their data collection people what is best practice around this, and is there some reason that we should change our collection measures. Because addressing racial and ethnic disparities in care is a really high priority for us here at CPCQC. And we realize that our ability to do this really hinges on our ability to collect really consistent and high quality data, allows us to look at these in a more granular way. So know that we're working on it outside, keep you guys in the loop. If you have feedback for us on how your hospital or your EMR is collecting race and ethnicity data, we would love to hear it, and either in the chat or by email.
Thank you, Amber. And now moving on, studying the data once again at the patient level. Here we are again looking at the 96 patient submissions that received on substance use. And this is just based on the categories of substance use being reported thus far. Coming at most is 40% for stimulant usage, 37% for depressants usage, and then 35% for other substances, which is primarily cannabis. We do also ask for other substances such as non-prescription substances or misuse of other prescription substances that are not listed here, but those were 0 reported so far. And then 19% of patients with opioid use and 0% of hallucinogenics. Bear in mind, these substances, the uses overlap, so it's not 100% across the board, because there are various substance uses, polysubstances uses across the board for stimulants and depressants, or stimulants and opioids, or vice versa, opioids and depressants. So even with the preliminary data on substance use, we caution drawing correlations between data as of yet, because our inferences may change over time, since our number of values for collection is very small, and that will also change on the usage over time. The data reflects the need to focus on SUD screening more broadly though, so not just limit to opioids. As you can see, the most commonly reported substances are stimulants and depressants. So we continue to rely on you all to submit your data to us on both patient level and hospital level, so we can draw inferences there. Moving over to the next slide, one of our next funnels that we speak upon within our slides is in looking at the patient level data, again, of the 96 patients who's positive for substance use. This is on any substance. One clinical care practices that we are adopting within the hospitals. 77 of them reported having consultation with the social worker prior to discharge. 58% reported being counseled on recovery treatment services prenatally or during birth admission, while 41% reported receiving recovery treatment services at any point prenatally or during birth admission.
So far on the slide that Stacey just presented, the data show a relatively low number of patients who are screening positive for substance use disorders or actually receiving a consultation, counseling, or treatment. We all know, and we talked about this in our last session when we talked about PMADs, that screening alone does not change clinical outcomes, that we also have to focus on the quality improvement about how we are handling the positive screens. And this shows us that there's an opportunity for improvement on how we're handling patients who are screening positive. So there's a few questions that your unit might want to ask on how you're handling a positive SUD screen. Do you need to develop a more detailed flow on how your frontline providers are managing a positive screen? If that's true, then we can help. You need to get more targeted feedback from the nurses on your unit about how they're collecting screens and what they do when they get a positive screen. Some sites might benefit from doing a multidisciplinary meeting with the social workers who are actually providing those consultations prior to discharge. Maybe they need to be involved in creating that workflow to make it a smoother process for you. And then possibly you need to host another education session for your nurses and your OB providers on how they're handling positive screens. Maybe they just simply need more guidance on what the next steps are. So as you're deciding on new tests of change, possibly one of the ones we mentioned, maybe you already have your own test of change around this that's in play. Again, I think it can be really valuable if you could aim around that. I think that those numerical values mean a lot to people who are working towards a common goal. And an example I gave here is, again, by January 23, 90% of patients who screen positive for substance use disorder will receive a social work consultation prior to discharge. And just to remind you, our current rates for those consultations are 77% among the cohort. So again, there's room for improvement there.
Thank you, Amber. Now we're going to again look at the patient level data, but in more granularity. We're only looking at the 18 patients that screened or identified themselves positive for using opioids. And in particular, we're looking at the number of patients counseled on MOUD. In this particular bar chart, we see that 12 of those 18 patients were counseled. 67% is what we are showing here. One was not counseled, while 5 are unknown on counseling for MOUD during birth admission or prenatally. So we definitely have room for improvement. Once again, we look at the same 18 patients and whether those patients received MOUD prenatally or during birth admission. 11 received it, which was 61% of those 18, and 22% did not receive 4 of those, and 3 is unknown. This presents another opportunity for improvement. When we look at the patients that were actually initiated MOUD during birth admission, we see a bigger difference in regards to those that were actually initiated during birth admission, as 5 of those 18 were 20%, 10 was not initiated MOUD during birth admission, while 3 is unknown as well. And then overall, when we talk about those 18 patients that were identified as opioid use, the number that were referred to MOUD is striking, because we see that 3 were referred, 17%, 3 of those 18 were referred to MOUD referral to treatment, while 5% was not referred, and 10 those 56, and I'm sorry, are not even, we don't even know what to them. So this is a surprisingly high number. We like to figure out why were they not referred to treatment. Now we continue to look at these 13 patients and those that reported MOUD use out of the 18 that have opioid. These are the 4 different types of MOUD use that those 18 patients have reported. I won't go into detail, that y'all read that, but that's something to consider in regards to our data collection. And then moving on, finally, we're going to look at the data that we've collected so far on naloxone, whether patients were prescribed naloxone or left with naloxone in hand, and just looking at our naloxone clinical practices. Of the total 96 patients screened positive for substance use, only 6%, I'm sorry, were prescribed or left home with take-home naloxone. No, 37% of them not prescribe or leave home with naloxone. It's 32% were unknown and 5% it was not applicable. Note that not applicable means that the hospital was indicated they were not able to prescribe naloxone on site, or they did not have naloxone on site. So with a number of the hospitals in our cohort participating in the naloxone project, we expect these rates to increase. And it's certainly an opportunity for us to improve on evidence-based practice that has the potential to save lives. So.
So we wanted to finish by giving some kind of targeted observations for the analysis that we just went through on the patient level data. Only 67% of the patients who screened positive for opioid use disorder were counseled on MOUD during their birth admission. This is certainly an opportunity for improvement for us. A few questions that we have is the problem a nurse or provider education issue? If that's the case, then certainly we have great education tools that we could provide you for your staff. Do you need more partnerships with MOUD prescribers? And one of the things our team was talking about is that even if you don't have OB providers who are equipped to prescribe MOUD, you can partner with the ER doctors and the ER providers for offering that service. And so if that's a partnership that your hospital needs to develop further, again, we'd be happy to help facilitate or give advice on that. For the patients who did receive counseling, who provided this counseling? We're curious about, is this the nurse that's counseling? Is it the provider? Is it the social worker? We're curious about your workflows for that. And if that workflow is working for your hospital, we'd love to be able to offer that workflow to other hospitals so that they could benefit from it as well. 5 of the 18 patients who screened positive for opioid use disorder initiated MOUD during their birth admission. And I see this as both a win and an opportunity. So for those 5 patients, that's a really big step that they were taking in their journey for treatment. Again, for those hospitals who are offering MOUD initiation during the birth admission, we want to know which prescribers are initiating that. Is it your OB providers? Is it your emergency room providers? We'd love insight on how you're making that happen. Because that's something that could be replicated in our other sites. 24% of the patients who screened positive for OUD, opioid use disorder, did not receive counseling, initiation of treatment or referral, or it was simply unknown if they did. And this represents a big gap in care where the patients that have a need, are identified a need because they've screened positive, are falling through the system. And it also offers us an opportunity for improvement. So we have questions around this. Is the problem with your hospital's workflow for managing positive screens? Do we need to tighten up that workflow? Is it a lack of opioid use disorder or MOUD resources in your community? How can we you in that? Do we need to provide better staff training on managing positive screens for opioid use disorder? And I think there's a possibility here with the high number of cases that it simply was unknown if the patients received counseling, referral, or treatment. Is it that this care is being given, it's just not being documented? And that again is a workflow issue. Do we need to sort of tighten up what's happening at your hospital and where your providers are documenting the care that they're actually giving? From a QI perspective, a driver diagram can be a really great tool for identifying these types of gaps. And again, we would be happy to schedule one-on-ones to talk about how that might benefit your sites to sort of address what's the best step that we can take to address these gaps in care. So, I mean, I would say these are the things that our team sort of highlighted as issues that we wanted to bring up and opportunities that we'd like to help you address. But if something else came up when we were covering this data that you thought, gosh, that's an issue at my site as well, or I could see that our site might need improvement in that area as well, then we want you to address that's what's most applicable to your work site and for your hospital and for your providers. So identify those things, bring them to us. We would be happy to troubleshoot them with you.
Amber, I just want to jump in and call out 2 things from the chat. One is Amy Dempsey noted when we were asking about, like, you know, why is some of this not happening, that some of the patients didn't receive information because they left AMA or like they've arrived without prenatal care and then they leave AMA. So that makes sense and is helpful context. Another thing, so Mariah asked if any organization has tried providing naloxone universally for maternal patients. And I think Mick is going to try to do that. So I wanted to give Mick a chance to chime in.
Yeah, we are working with the naloxone project to hopefully just do a universal, everybody gets a dose, and then we will see how that works. We're going to do kind of an IRB around it, so it will be published. And I think we're looking at another hospital joining us too, but I want to say that hospital until I know it's happening. And that way it will be published and we can kind of see, we're not trying to make women feel shamed, but we know this group that we can get doses out into our community, and whoever needs it then could hopefully, whoever we save, could be a dad, could be the uncle, it could be a cousin, or it could be this mom. So we're just trying to get doses into the community, and we're going to see how that works. But I think we should be starting that this fall is our goal. Written on paper.
Well done. That's such a win for your site. Thanks for sharing. Hopefully that'll maybe inspire some of our other sites to sort of jump on board or see how their hospital might be able to do an opt-out process like you guys are doing as well. I think again, we talked about this last month when we did our PMAD talk that, perinatal care is such an opportunity within healthcare that we don't see in many other populations, that we're seeing patients typically more than once in the year. We have more routine care with them. And this is an excellent time to capture not only sort of the care for that patient, but for the whole community that lives around that patient. And so the fact that you guys are sort of doing it universally, I think it's an excellent win. Well done.
Yes, thank you so much, Meg. I appreciate you sharing that. That's awesome news. So going on, Amber, we will look at some of the data that Amber collected in regards to the qualitative data. Did you want to go forward with the Jamboard? Do we have time?
I know we're maybe a little bit time. We had compiled some of the qualitative data that the teams had shared with us. We really think that that data that you guys are submitting on the monthly qualitative forms is so valuable, and we really learn a lot from it. And we think that it's valuable that we share your insights with the other teams. What we might try to do is do something like this in a future session where we sort of, as a community, discuss back. I think today, for time purposes, we'll keep moving on.
Thank you, Amber. And the slides will be available to y'all. So y'all can go look at our Jamboard to see what Amber put together in regards to the qualitative data as well on your own time. So on is our another kind of act stage, and Amber will touch on our third funnel of the
So we wanted to come back to this funnel graphic for our initiative. We started by showing you the graphic that's on the left that represents our current state. So where we're currently at with collecting data and what the data is telling us. But our goal is to move towards the funnel that's on the right. And clearly you can see here that that funnel is wider. It's capturing more patients through screening and through clinical care. The goal is universal screening for all patients. So as you can see, the green at the top and the blue right below it are almost equal. We want all patients to be screened for substance use disorders. And then that should be followed by clinical care for all positive substance use disorder screens. Again, that middle portion all the way down to the bottom is a much wider catchment for identifying patients who have need and then actually acting upon that need. So the number of patients receiving treatment should be closer, if not equal, to the number of patients who are identified as having substance use disorder.
Now, we've gone almost full circle. We've been through our plan, do, study phase. And again, we still are studying our data. However, we continue to think about what we're going to do in our act phase and what we've learned from the studies. We've learned data analysis and all the visualizations. We continue to sit and tell the story from the, but we plan to hospitals with more QI coaching and integrate more QI tools such as driver diagrams and setting aims and getting with Amber and setting those PSA cycles as we do here and creating those 30, 60, 90-day goals based on these findings. We want to host a focus group to get further feedback on data collection, and we want to data lesson that improve data collection overall for the hospital level forms and the patient level forms, and increase that data submission so that we can continue to review what we are doing and also apply any small tests of change based on this data. we're already getting some great suggestions and feedback. So we want to hear from y'all on what you're doing in race and ethnicity data collection, the payer insurance type information, as well as improving the clinical care aspects for those positive screens. So this is our final and big ask of y'all. We ask that those of you that have the capacity to, we're requesting for volunteers in those focus groups. We need your help to refine our processes on data collection and create a better methodology so we can move forward with our Q3 data so we can see more data submissions, both hospital and patient level data. We'll close out Q2 and we will be reporting to y'all based on what y'all have submitted and then move on to Q3. So again, focus on that. We want to remind you that as you submit data, make it easier on yourself, save your time. You don't need to submit for patients under the age of 18. Although we do filter on that, we will omit those, but that will save your time if you don't have to do that. Please help us improve data collection quality, and remember that I will be sending you those data quality check emails. So now you see my face to the name and I will email you and say, hey, I just want to check in on you to make sure that what you entered is right. Maybe you got interrupted while you were entering it and you meant to submit it, but we're not able to submit it as complete because we did have several incomplete submissions. So please let us know if you need our help in getting that data quality check. Don't hesitate to reach out to me or Amber, and we can certainly use Amber to do more one-on-ones, as well as I can certainly meet with you one-on-one on entering data. Let us know if you have any questions. You can come off mute, you can put it in the chat. Maybe a question comes up later on, you can email us at info@cpcqc.org. And maybe you do want to schedule those one-on-ones, please email us. Things so far, anything from your ends, everyone? So we will move on to the team presentations. And I think first we have Valley View. Do you all have a slide or do you?
Yeah, do you want me to share my screen?
Sure.
Yes.
You have access, Mick?
Yes.
Awesome. Go ahead.
Are you seeing my screen? Okay.
Yep.
Okay. Now I gotta make it. I'm gonna just shut this down. Sorry.
Mick and Tina are in the same room, so they're trying to figure that out, I believe.
Hey. Okay. So Tina's here with me because Tina helps me do a lot of this work. So, but we screen all our patients on admission for every admission, for clinic visits, for NSTs, for whatever reason. If they're on IV iron, we screen every patient, including our labor patients. And we do use paper because the evidence has shown that paper people are more honest. So when they are done with their admission process, if they aren't in too active of labor, then they will kind of do the screen. We do an EPDS and we do early. And then if we do have a positive, we have the nurses talk to the midwives, and we do notify a social worker that works at the clinic that screens them also prenatally. We're very blessed. We have one clinic that all of our prenatal care comes from. So it's easy for us in some ways because we have a great relationship with our clinic. We also do the EPDS during prior to discharge again, and make sure that the score is similar or did not change, because we all know that if people have that they didn't expect to go they wanted, they may be depressed about that. And so talking about that and getting a number again is very helpful. This is just the brief screening we use for the alcohol and drugs, very short, sweet and to the point. And then if our brief screen is positive, we'll go into a bigger screen. We have ongoing education to keep up with SUD. It's every month on our staff meeting agenda. And then we've asked all the staff to sign up for expert training, and we only had a few people that did it. So what we did was we brought Kevin Hughes into a staff meeting, and this was much more successful. More people understood, and it was great. and everybody was very engaged. We also were blessed to have Don Stater from the Naloxone Project come to one of our Women's and Children's Service Line meetings. And he talked about what the state's doing and how we were involved in the prenatal part, but we hadn't given any doses out successfully. And so our providers had a great discussion with him, and that's where they kind of come up with the opt out instead of opt in for naloxone. And maybe we should just try to give everybody a dose because we know it's in our community. And so he was very excited that our doctors were so engaged, and that's kind of where we got started with that. And I think other things that are very helpful for us is that we do have monthly meetings with our behavioral health specialist and our social worker from the clinic, just to make sure that we're all still doing the same things and just have a touch base, and that we continue to work together. So making sure they're getting all the screenings they need and help at both places. So I think that's very, really been great for us. Barriers like all of you guys, turnover, and helping us continue our education with all the new staff, making sure they're all there and we filling all our gaps. I think that's been it's been a challenge, but we've been able to kind of keep up. And then moving ahead, we're going to try to meet with the clinic and our outside partners, and we're going to do this at least quarterly, if not more, if we need to. It's really been great because I learned, and Tina can say the same, that we had partners we didn't know we had there's people in our community that we didn't know were even existing until we started to reach out to people. And so I think it behooves everyone to realize, what do you have? And we just recently got our social worker, Barb, and she came from our Mountain Family Health Center, which is a Medicaid clinic. And she has a lot more resources, and that's been beautiful and wonderful to have. So we know that as long as we meet with these partners and we all kind of keep communicating, and what we can do for each other has been really, really awesome. We're also working on getting ACEs in the clinic prior to labor and delivery, so that we can kind of know how to handle them during labor and delivery and not while they're here, because that could bring up some trauma for some people. And then working with the Colorado Naloxone Project to do the opt-out is very exciting for us. And like I said, we're hoping to start that this fall. And we're just meeting with Dawn and some of our providers to kind of keep that. And then, having a script and making sure patients don't feel like we're trying to just give them naloxone because we think they're addictive, or that we think they're using, or we believe somebody in their family. There's going to be some really careful scripting to make sure we aren't making people feel shamed for giving them a naloxone dose. And that's all I have. I talk really quick.
Thank you so much, Mick. I think the next presentation I have is Denver Health. Do we have someone here in Denver Health for that?
I don't think Denver Health is here, but I do see a question in the chat from Mary Sundland. It says, are hospitals using a plan of safe care for the families with a caregiver who has SUD, so that there's a warm handoff to the baby and caregiver and to the sports in the community? If anyone wants to come off mute or put in the chat, Mary would be appreciative.
Yeah, this is Mary. And so it was just, I know this is totally kind of out of left field here because it doesn't have anything to do with the data collection that you guys are working on, but it just occurred to me that I'm working on another group of providers who are working on plans of safe care for substance exposed newborns going home. And I didn't know if once someone is identified and taken care of and counseled in the hospital, if there was a plan for them going home. So just extending it out of the hospital back into the community.
At Valley View, we would probably use social services if needed. If not, we do make sure that our pediatricians, our OBs, everybody is kind of aware of this family. And then if there is another resource we can share with them, but we have like the family visitor, which is now great expectations that we want to make sure that this family is also involved in with a nurse partner. And yes, we also are chosen hospitals. Most of, I think, the group here is chosen hospitals as
Right.
well. So I think we did very well focus on the baby and the family. And with this, the substance use disorder group, I feel like we're really trying harder to keep families together than just calling social services.
Mhm.
So that's our goal. And then making sure we have these things to support families is the most important.
Absolutely. Thank you.
Yeah, I also wanted to mention that in October, I believe, Kitty interrupt if I'm wrong, but we're going to be having a webinar on a very similar subject, but about kind of next steps with child welfare in labor and delivery units. So definitely join that one if you're interested in hearing more about that. Does anyone have any more questions for Mick about her presentation? I know that I'm really excited for them about their opt-out approach. I think that that will really have a larger net. Well, if not, I'm going to pass this over to Katie because I know she has a few questions for y'all.
Yes. So, a year ago, actually, for teams that participated in 2021, in August of last year, our coaching call topic for that month was guidance about breastfeeding for patients who use cannabis. And there are a lot of there's a lot of research, there's a lot of ambiguity in guidance that's out there. And so we are excited that next month, CDPHE, basically they just released new guidance that's like coming from the state for what sort of breastfeeding counseling you can give to patients who use cannabis. And so in preparation for that presentation, we really want to make sure that it meets your needs, especially given that we know that the presentation last year in a lot of ways raised more questions than it gave answers. So we put together a poll that I'm going to have you fill out to let us know more about the breastfeeding guide, like the breastfeeding guidance policies that you have right now for people who use cannabis. And so Elena launched the poll. It should be on your screen. If you can fill it out, I'll stop talking so you can read it. But I'll give people a couple minutes to fill that out, and then would love to verbally discuss as well.
Can you all see the poll? No.
I can see it.
Let me
I
try
can see
again.
it. I can see it too.
It might
Okay.
be like hidden behind different
Yeah.
windows, or if you have like a second screen up, it might be on that.
Yeah, like usually pops up in a second little window.
Yeah.
Oh, someone's doing it. Tina, can you still not see it? I see you shaking your head. I can.
Can Nick see it? Oh. Okay.
Do you
We'll
want
give
me?
you a couple minutes and then we can always read them out loud.
Yeah, do you want me to share my screen? Maybe you can chat them in? Or do you want it to be anonymous? I don't know how we want to do this.
It doesn't have to be anonymous.
Okay, I'm going to share my screen. And you can look at them with me. Okay, hold on. Okay, can you all see that?
It's just a bunch of windows, but it's not like the Zoom window.
Oh, what the heck? I'm really struggling today. I don't know if I can share the Zoom window.
Yeah. Okay, that's okay. Everyone filled it out. I don't see like
there's
I
still
can't see
people
this.
coming through.
Yes.
There's still people.
I filled it out.
There's people coming through with it.
Okay.
The
We'll give
validity
it like
team's
a
just
minute and then
slacking.
we can go through the questions.
Okay, I ended the poll. Do you want me to share the screen, Katie?
Yes, please. Okay, so we'll go through the questions and then also the answers that we received. So the first question was, does your organization have a policy on breastfeeding guidance for patients who use cannabis? So of the people who were able to use the poll and respond, 44% said no, their organization does not have a policy on this. 22% said yes, we have a policy, but the guidance is unclear for clinical practice. And 44% said yes, and it provides useful guidance. So that's great. For the folks who answered or who couldn't use the poll and couldn't answer, if you're able to come off mute and provide some color commentary, that would be helpful. And Amy, I think they are about to release it. So I don't think they've released it yet, but it's supposed to be released like by the end of this month, I think. And we're definitely going to share it. Anyone want to come off mute? Give us some details?
I think from my experience, a lot of the hospital sites have guidance, often says the hospital does not recommend breastfeeding for moms who report case use. But in clinical practice, that's really challenging because you can't actually stop a patient from breastfeeding. And so I think that's where a lot of the ambiguity comes for frontline providers, is that the policy says we can't recommend it, but in clinical practice, you actually can't stop it.
Yeah, and I think, you know, the guidance that CDPHE will be releasing recognizes that and tries to take a harm reduction approach. So I don't know what this is, but I know that is feedback that they really took to heart when they were making the guidance. So Amy said, we provide the CDPHE education sheet and recommend against breastfeeding if using marijuana. So Amy, does that education, like the education sheet you have, which I assume is like older, does that from CDPHE say that you recommend against it? Okay, so I'll move on to the second question. And it is, what are the most common challenges you encounter when counseling patients regarding cannabis in the perinatal period? So 60% of people said the patients are not interested in information and counseling. 40% said I need more training on how to have these conversations. 40% said I'm unclear on evidence-based information on cannabis in the perinatal period. 20% said my organization has unclear guidance on patient education, and 10% said my personal beliefs about cannabis use differ from my organization's guidance. So can anyone tell us more about what they said?
There's just one more category too. Maybe if we scroll down, it
sorry.
There's not outpaid resources for patients.
Thank you. Yeah, 40% said that we don't have, my guidance for patients lacks resources for the patient in the outpatient setting. Wow, I said patient a lot in one sentence.
This is Debbie at St. James, and our patients do not see cannabis as an issue. So they're not interested in hearing, like, you know, we give them some information and they are not interested in really listening to that information because they don't see it as a problem. I had one patient tell one of my nurses, it may be a problem for you, but it's not a problem for me. I think it's, you know, the mentality also of the client, of the patients that are out there, that really, if they don't see it as a danger, then it's hard for us to convey that to them with no matter what data or resources you give them.
That makes sense. Leah said that they had signed a waiver about breastfeeding and use of THC, which mostly states that we don't know the long-term effects for the well baby population. NICU babies are not allowed and they have to use donor milk if available.
This is Mick, and I have to say, I agree with Debbie. Most of our patients don't feel like, because it's legal, they don't feel like it's a problem or can't harm a baby, even though alcohol is legal. They'll, we see less alcohol than we used to see. But marijuana, it seems to be like it's no big deal. They don't really want to hear it. We highly discourage it, but we try to look at the risk benefits of breastfeeding versus smoking and decide with the patient, how much do you smoke? Are they even being honest with you? And how hard do we discourage it? It's better for them to have a fed baby. And if that's the way they can feed their baby, but it's definitely a challenge.
Yeah. That makes sense. The next question, suggestions that you might have for your organization's policy around cannabis and patient counseling would include. So 0% said that the policy is too ambiguous. 57% said the staff need training on the policy, including how to provide effective patient guidance on breastfeeding and cannabis use. 14% said the policy needs more evidence-based information to help me counsel patients effectively. 29% said the guidance needs to include more resources for patients. 43% said it needs to address the lack of consensus among OB and pediatric providers at my hospital on patient education regarding cannabis use. 29% said the policy would benefit from input from frontline providers to offer patient education and guidance. So anyone want to tell us a little bit more about why they answered the way they did?
It definitely makes sense to me that people are highlighting the need for provider education around this. I think it's not that the guidance is unclear, it's that how do we communicate that guidance effectively to patients?
I'm curious, like, if you have lactation counselors in your hospital, are they the ones that are talking to patients about this?
I think it's a team effort in most hospitals. Right? It's the provider, the nurse, and the lactation consultant, and often the pediatric provider as well.
Well, I know that we're at time, so I'm going to launch the evaluation poll really quickly. But if anyone has any more thoughts about this, it does pertain to our next coaching call in October or in September. I'm jumping ahead of myself. And so please feel free to email us if you have any questions, but we know we're on a time crunch. So if you have time, please fill out the evaluation. And we really appreciate you all joining today.